Hello, I'm Sean Steen. I'm the Director of Surgical Oncology for Anacapa Surgical Associates and the Ventura County Medical Center. This is an update on cutaneous melanoma using the most recent version of the NCCN guidelines and going over the AJCC version 8. So melanoma is about 5% of skin cancers, while 95% of skin cancers include things like basal cell carcinoma and squamous cell carcinoma. But melanoma is increasing in incidence. This is data from the SEER database in America showing that the rate per 100,000 persons has gone up steadily over time, and we're close to 25 per 100,000 now. Estimated new cases in America in 2022 is close to 100,000. It's about 5% of all new cancer cases and about 1% of all new cancer deaths. And the 5-year relative survival is about 93% for all comers. So for the county that we live in, population's around 840,000. So at 24 per 100K incidence, we could expect over 200 melanoma cases in our county. The initial diagnosis of cutaneous melanoma is always good to know about. We talk commonly about the ABCs of melanoma. The A standing for asymmetry. So a normal mole has a round shape without irregular borders, but the asymmetric borders is a sign of melanoma. The B stands for borders also, and that's an uneven, ragged, or notched border. C is for coloring. A normal mole usually has a heterogeneous color, a different shade of brown, black, or tan, or variegated color across a mole may be a sign of melanoma developing. And the diameter that's increasing or larger than the size of a pencil eraser is also a concerning sign for melanoma. The types of melanoma are a combination of a clinical and a pathologic diagnosis. Probably the most common type we see is superficial spreading melanoma. That tends to spread out in a radial pattern in the surface of the skin. It can develop deeper invasion over time. Lentigo melanoma is a version of this. It tends to be melanoma in situ and tends to occur on the face or sun-exposed area in elderly people. The margins can be hard to find as it infiltrates through the skin radially. Nodular melanoma is a more dangerous type. This is sometimes diagnosed just on pathology, but it has a vertical growth pattern. It tends to grow deep into the skin and spread earlier than a superficial spreading type would because it gets down into those dermal lymphatics. Amelanotic melanomas are melanomas that don't carry the dark pigment and can be pink and are often mistaken for rashes or basal cell carcinoma or squamous cell carcinomas. Acrolentiginous melanoma is melanoma that occurs on the palms of the hands or soles of the feet. And subungual melanoma is a version of this that tends to occur under fingernails or toenails. And we'll talk more about those later. I like to include this slide to say that a surgeon usually does not diagnose the original melanoma. We don't see the ABCDs of the melanoma. Usually a dermatologist or a primary care doctor will shave biopsy or punch biopsy the melanoma. And what we see is really just a scab. On that note, I do think that if it looks like a deep, aggressive looking melanoma, we do prefer punch biopsies through the full thickness of the dermis so that we can get a good idea of what the true depth of the melanoma is. If you are going to do a shave biopsy on a suspicious melanoma, it should be a deep shave biopsy to the down into the deep dermis at least. The reason that we care about including the depth of the melanoma is that depth is the most important prognostic factor. We'll go over this a little bit more in depth, but essentially if a melanoma is down into the dermis layer, it can get into the lymphatics and travel to lymph nodes, and is much more dangerous. Another prognostic factor for melanoma is ulceration, which is the loss of the epidermal layer over the top. Clinically, a patient may note that the melanoma has been weeping or oozing, bleeding even when it rubs on clothes, and the pathologist can tell ulceration based on the original biopsy. Another pathologic factor that's important is mitosis, which is the process of one cell becoming two. Pathologists can actually see the process of mitosis and a snapshot in real time whenever a biopsy is done. The number of mitoses per square millimeter should be reported as a whole number and is not actually really part of the staging anymore, but it is part of the prognostic factors that we look at. This is the most recent version of the AJCC staging version 8 and from the most recent NCCN guidelines. Note here that the thin melanomas include melanoma in situ, but the thin melanoma that's invasive is anything up to 1 millimeter in depth. And we subclassify those as T1A is less than 0.8 millimeters without ulceration. T1B is 0.8 to 1 millimeter depth with or without ulceration. If the old staging manual, just version 7, they actually included mitoses as increasing it to a T1B stage, but they took that out again in the 8th version. So we no longer use mitosis to classify T1B. T2 melanomas are 1 to 2 millimeters in depth. The A and B classification have to do with ulceration. If they're ulcerated, they're T2B. Again, with T3, it's 2 to 4 millimeters in depth, with ulceration increasing it to T3B. And T4s are thick melanomas, anything over 4 millimeters in depth, and anything with ulceration is a T4B. Generally speaking, we say thin melanoma includes anything less than a millimeter. Intermediate thickness melanoma are 1 to 4 millimeter, and thick melanoma is over 4 millimeters in depth. So to get into the surgical treatment of cutaneous melanoma, the first step is to remove the primary tumor. Second step we'll talk about is checking lymph nodes for tumor spread, when and how we do this. So melanoma cells theoretically can infiltrate into the surrounding skin with skip lesions or even sometimes even direct extension. So we want to remove a rim of normal skin around the melanoma to be sure we get any cells that have escaped from the primary lesion. For an in situ melanoma, we recommend a 0.5 centimeter margin circumferentially. Thin melanoma, less than a millimeter, at least a centimeter of excision margin. Intermediate thickness melanomas, 2 centimeters if you can. And for thick melanomas, at least 2 centimeters. Sometimes we take a little bit more, but 2 centimeters has been generally shown to be adequate even for a thick melanoma. But if you have loose skin and you're able to take a little bit more, you should go ahead and take a little bit more if you can. So people and patients often say, what's 1 to 2 centimeters does not sound like a lot. What's the big deal? Why do I even have to go to the surgical operating room? And what happens is that if the biopsy scar itself is about 1 centimeter in diameter and you add a 2 centimeter margin circumferentially, you easily get up to about a 5 centimeter skin defect. A 5 centimeter skin defect that is closed with an ellipse has to be about 3 times as long as it is wide. So you can get a 15 centimeter long incision pretty easily. Then you have to raise skin flaps and pull that together, which obviously is a fairly large working area, something that's typically done under general anesthesia in an operating room. This would be an example of a wide excision of a melanoma of the forearm. And you can see a very large skin defect resulting in a 15 centimeter or 5 to 6 inch long scar in the long run. If it's somewhere that has tight skin, things kind of in the calf or the chin or the foot, the hand, the wrist, a lot of the head and neck, scalp area, you really just need to do a skin graft. There's no way to pull together a wide excision of a melanoma with wider margins. Split thickness skin grafts are typically used. Rarely we'll use full thickness skin grafts. Second part of surgery for melanoma would be checking the lymph nodes for tumor spread. The most common way we do this is the sentinel lymph node biopsy. So we'll break this down into why we do the sentinel node biopsy and who we do it in and how we do it in. So for the why, if somebody comes in with palpable lymph nodes with the diagnosis of melanoma, we would do probably core needle biopsies or some other technique. We would not use the sentinel lymph node biopsy with clinically positive lymph nodes. The reason that we use a sentinel lymph node biopsy is people that you cannot palpate lymph nodes or the lymph nodes are not enlarged radiographically. So we want to know if the melanoma has spread to these lymph nodes microscopically. So that's when the sentinel lymph node biopsy is used. In the old days, if somebody had palpable or even non-palpable lymph nodes, and they had intermediate or thick melanoma, many surgeons would go ahead and just prophylactically remove all of the lymph nodes in that basin, this being, say, the axillary lymph nodes. And you may end up with about 20 plus lymph nodes in your specimen, which could lead to things like lymphedema, lymphedema of the arm, for inguinal lymph nodes, lymphedema of the leg, which can be quite a troublesome problem for the patients. And what we found was that when you routinely did full lymph node dissections for intermediate and thick melanomas, only about 20% or 1 in 5 of those people actually had metastases in their lymph nodes. So theoretically, 4 out of 5 people were having the dissection done, possibly without much therapeutic benefit. So the technique of the sentinel lymph node biopsy was designed to decide who actually contained melanoma in their lymph nodes and who may benefit from the larger lymph node dissection surgery to remove more lymph nodes. So the original studies looking into this were done by Dr. Donald Morton. The Sentinel trial was the MSLT I study. And during that study, they took patients who had melanoma and intermediate and thick melanoma, and they assigned them a wide excision with a sentinel lymph node biopsy or wide excision and just watching the lymph nodes. And if they reoccurred with palpable lymph nodes in either group, then they went on to a completion lymph node dissection. And they followed the patients for 10 years looking for systemic reoccurrence and survival. So the total number of patients randomized was over 1,500. About 1,300 plus had intermediate thickness melanomas, and about 300 or so had the thick primary melanomas. The intermediate thickness, which in this trial was defined as 1.2 to 3.5 millimeters, just slightly different than the actual AJCC staging, had nodal metastases in about 20%, which is historically what we would see in completion lymph node dissection specimens anyway. The thick melanomas, though, the patients who had over 3.5 millimeter thick melanomas did have a nodal metastasis rate of 40%. So this MLT1 study did show that disease-free survival in both the intermediate and thick melanomas was improved with the use of the sentinel lymph node biopsy, and the mean positive sentinel lymph nodes, meaning how many lymph nodes actually had melanoma and when all the surgery was done, was a lot lower. The sentinel lymph node group had 1.4 positive sentinel lymph nodes, whereas patients that went on to develop clinically positive disease in the observation group, meaning somebody could feel a lymph node or it came up on an ultrasound as abnormal in the future, when those patients went on to have delayed completion dissections, they had 3.2 positive lymph nodes. So well over twice as many positive lymph nodes, which one would assume led to worse prognosis because they had a larger tumor burden, also led to worse lymphedema and things of that nature after completion dissections. The other important things to note on these trials was that an intermediate thickness melanoma, 1 to 3.5 or so, if they had a positive sentinel lymph node, the 10-year melanoma specific survival was 62%. If those intermediate thickness melanomas had a negative sentinel node, the 10-year survival rate was much better, 85%. And if you look for thick melanomas, in this case being deeper than 3.5 millimeters, a thick melanoma with a positive sentinel node had a 10-year survival rate of about 50%. So, and a negative sentinel lymph node in a thick melanoma had a 10-year survival of about 65%. So you'll note that a negative sentinel node with a thick melanoma is almost the same survival as a node positive intermediate thickness melanoma. And in the current staging system, as we'll talk about a little bit later, they're actually classified fairly similarly in the staging. And now we're actually looking at adjuvant therapies, even in the thick melanomas with negative sentinel nodes, because they also have a fairly poor survival. So here's the general staging groups. So if a patient has a thick melanoma at presentation with clinically negative lymph nodes, they're staged in the high-risk stage 2. If they have a positive node at presentation, they're automatically put into a stage 3. These are subclassified differently after pathologic diagnosis, but not to overwhelm us at this point in the talk. I'm just going to go into that a little bit deeper later on. But generally speaking, anything with positive lymph nodes, whether it's clinically detected or found on sentinel node, will put you into a stage 3 melanoma. And obviously metastatic disease is going to be stage 4. Also in MSLT they showed that the sentinel lymph node, not only is it help with staging and possibly a therapeutic benefit, but it has a very big prognostic value. So the sentinel lymph node status of being positive versus negative had a hazard ratio of 2.6% with a very good p-value. And this actually had a better prognostic indicator, as in whether you were going to do well or not, as compared to almost any other value they looked at. Breslow thickness was the next best prognostic indicator. Ulceration did have some very good prognostic indication, as well as being in a difficult area like the head or neck. The other reason sentinel lymph nodes are nice is just when it comes to looking at it from a pathologic standpoint, it gives us a lot of information with the least amount of effort from the pathology department. So a pathologist can take a single lymph node and get very accurate diagnosis using things like immunostains with HMB45, melanin A, or MART1. And they can find very, very small metastases in the sentinel node, even a single cell or a cluster of cells. So you can get ultra staging, meaning you're just very accurate in whether the lymph node contains melanoma. And if you assume that a melanoma metastasis in a lymph node, which is represented here with a jelly bean, is a small, maybe 1 or 2 millimeter deposit, a traditional lymph node sampling, if you did a full lymph node dissection and gave the pathologist 20 or so lymph nodes, they're just going to bivalve the lymph node. They're going to look just at the middle of the lymph node, and they may miss a small deposit somewhere on the subcapsular area, not where they cut. So you could get a lot of false negative lymph node reads if you did full lymph node dissections in everybody, whereas a sentinel lymph node is supposed to be cut at intervals of 1 millimeter or 2 millimeters. So it's much easier for a pathologist to find a small metastatic deposit doing this technique where you are cutting the lymph node at intervals. Versus if you gave them 30 plus lymph nodes and you asked them to find the one lymph node that had a small subcapsular 1 or 2 millimeter deposit, it's going to be very difficult for that pathologist to do that. And their techniques and the amount of slides that they would need to do to find that, it's just not possible. So the pathologists really appreciate the specificity of giving them a single lymph node to check versus 30. As far as a sentinel lymph node biopsy, as in who to do it on. So if you look at the current AJCC staging, basically everybody who's T1B and up should be considered for sentinel lymph node biopsy if they do not have clinically positive lymph nodes. So if a patient comes in with a melanoma of 0.8 thickness, I would offer a sentinel lymph node biopsy. The NCCN guidelines specifically say to discuss it with them. It doesn't necessarily say you have to do it at the 0.8 to 1 millimeter, but I tend to offer it in anybody who's a good surgical candidate. If somebody comes in with a less than 0.8 millimeter melanoma, but they do have ulceration, that actually is still considered a T1B and should go for a sentinel lymph node biopsy. Occasionally I get patients who have maybe a 0.7 thick melanoma, but they have a positive deep margin on the shave biopsy. And they could easily have that additional 0.1 millimeter missed. So if they're close to the 0.8 mark and they have a positive deep margin, I may offer them a sentinel lymph node biopsy also. The how is big to the surgical oncology world. We like to talk a lot about how we do sentinel lymph node biopsies and the pitfalls. We'll go over some of those things real quickly. Generally speaking, we use 2 types of dye to find the sentinel lymph node. We inject the primary tumor with a radioactive dye that tends to stick in the sentinel lymph node being the first draining lymph node from the area of the skin where the melanoma is located. We also inject a blue dye, which is lymphozerin blue, into the area around the melanoma, which tracks to the lymph node and sticks in the same lymph node as the radioactive dye. So there's 2 ways of finding the same lymph node. I have no financial attachment to Lymphoseek, but that is what we use in our institution. So I feel like I should mention it by its brand name. But Lymphoseek does have a small molecular size of 7 nanometers, and it has mannose in it, and this is a sugar molecule. And there's certain receptors, such as the CD206 receptor, which are found on certain immune cells like macrophages and dendritic cells. So when we inject Lymphoseek into the primary melanoma, it tends to be taken into macrophages and these dendritic cells in the subcapsular sinus of the lymph nodes themselves. And that's typically where we look for the melanoma metastases. Also, they tend to occur in the subcapsular sinuses. So the Lymphoseek is taken up into the lymph node and stays there, and it'll stay in the lymph node for 48 to 72 hours. Typically, I'll inject the patient with our nuclear medicine doctors the day prior to surgery, possibly the morning of surgery, and then we will do their images and then take them to surgery within 24 to 48 hours. This is an example of the primary injection site. It has a lot of radioactive signal, and there's a sentinel node in the left lower neck. This is an example of an injection on the thigh, and there's some sentinel lymph nodes in the groin. Usually, if there's multiple lymph nodes in a chain, we count the first lymph node, the one closest to the primary melanoma, as the actual sentinel node, and the ones higher up are usually not removed and are counted as second or third tier lymph nodes. The one that's closest in the chain to the primary site is the one we typically target. The other component of a dye injection is the lymphozurin blue, which is a bluish dye that stains the lymph node visibly blue. So when we take the patient to surgery, we can find the lymph node in whatever basin we're looking for based on the radioactive signal, which we use a Geiger counter in the operating room. And visibly, when we get close to the lymph node, we can see that it's blue. The pitfalls to sentinel node biopsy are that most of the time we find the sentinel lymph node in defined basins. Most commonly for head and neck melanomas, it's in the cervical or the lymph nodes of the neck. For arm melanomas, it's going to be in the armpit or the axillary lymph nodes, and for inguinal basins, it's going to be, the lower extremity, it's always going to be in the inguinal basins for the most part. However, there are exceptions to that rule. Sometimes about 5 to 8% of the time we find ectopic basins with the sentinel node actually not where you would expect it to be. Examples of these ectopic basins would be the intermuscular triangular space in the back, the epitrochlear region of the arms at the elbow, and the popliteal fossa behind the knees. So if you have a melanoma of say the lower leg, especially posteriorly on the calf or the forearm, a good nuclear medicine radiologist would make sure that those areas are screened with the images, as well as you should look for those areas with your node seeker in the operating room to be sure you're not missing an interval or ectopic node. Here's an example of a melanoma of the heel with an injection of the heel showing popliteal node uptake. And in this case, actually, there was also inguinal sentinel nodes, and both of them were removed and sampled. And we wrote our experience up from the John Wayne Cancer Institute when I was a fellow there, looking at management of the popliteal and lymph nodes in melanoma. And it's relatively infrequent, but it does occur occasionally, and it's happened to me several times in my own practice. Triangular intermuscular space has drainage from these spots on the back. So basically the upper back can drain into these lymph nodes, and where they're located is in the deep tissue of the back between the teres major, the long head of the triceps, and the subscapularis muscle. Typically when I find these lymph nodes, what we see is that the radioactive signal is not exactly in the axilla, and you remove the primary, and usually at the base of the primary excision. So you're actually already removed the skin and you're looking to close the incision on the back. Usually then you find the intermuscular space nodes, but you really have to be thinking about it. You sometimes need to remove the primary on the back before doing the sentinel node in the axilla, because there's a lot of a shine through radioactive signal coming from the area on the scapula, say where the primary was, and it's difficult to find the axillary nodes. And sometimes you figure out that after you take out the axillary nodes and you remove the primary, there's still signal deep in there, and that can be the intermuscular space, so it can be tricky. Generally, head and neck and the trunk are the tricky areas for sentinel lymph node biopsies. Head and neck is independently a predictor of worse survival in studies because there's a lower rate of positive sentinel lymph node identification, meaning we think that there's probably more false negative sentinel lymph nodes in the head and neck melanomas. Their lymph nodes are very small there. They're easily missed. There's multiple drainage patterns. The ability to find them in the operating room is harder. It's an example of an ear melanoma, multiple sentinel lymph nodes on the neck. It's hard to know which of these we should take out. I like to use SPECT CT. In fact, some of our hospitals now are doing SPECT CT for all sentinel lymph nodes, but I used to make sure we used it in head and neck melanoma, although it's used in the vast majority of melanomas at some hospitals now. And what it is they inject the primary tumor with radiocolloid, and it will go to the lymph node and stay in it just like a regular lymphoscintigraphy, but the patient's then put in this special CT scan that picks up the radioactive signal, and we'll show you anatomically where the radioactive signal is for the sentinel lymph node. This helps a lot with surgical planning, especially in head and neck melanomas, and knowing exactly where to find your sentinel lymph node. For truncal melanoma, many years ago, 20 or 30 years ago before the sentinel lymph node, we would assume that certain areas of the trunk would drain to either the axillary or the inguinal nodes. These are called the lines of Sappi. So anything on, say, the left side of the thorax would go to the axillary nodes. The right side would go to the right axilla. Anything below the umbilicus would go to the inguinal. We've actually found that that's actually really pretty inaccurate. This is a nice study from New Zealand and the Sydney Melanoma Unit. And what this is showing is that this is the percentage drainage likelihood to 2 or more lymph node fields. So you'll notice kind of in the back on the right side of the picture, in the midline of the upper back and then in the middle of the lower back, there's 80 to 100% chance that you're going to have 2 lymph node basins draining from that one melanoma site on the skin. So sometimes we'll take these patients and we'll have to do both axillary and inguinal lymph node excisions for the sentinel node, or you might end up having to do bilateral inguinal, or sometimes even more than that. So the trunk can be really difficult to find just a single lymph node, and sometimes you have to do multiple. These are showing the percent likelihood of drainage to the axilla. So of course the arm has about 100% chance of going to the axilla, but you can see there's anywhere from a 20 to 40% chance of drainage to, say, the left axilla on the top picture from things that are on the right side of the body. So the old lines of Sappi are not accurate. When you look at the modern techniques, we find that there's actually quite a bit of contralateral drainage going to the opposite side. And things from below the umbilicus can go to the axilla pretty frequently also. So the umbilical cutoff line saying that things below that would go to the inguinal area is actually not accurate anymore either. You can get drainage from things in the lower abdomen up to the axilla fairly easily. Same for the inguinal lymph nodes. Obviously, things in the leg will go to the inguinal lymph nodes, but many things on the contralateral trunk, things above the umbilicus, will drain to the inguinal lymph nodes, even on the opposite side. So the nodal drainage is unexpected in at least 30% of cases. The posterior trunk has a high incidence of contralateral nodes. And these interval nodes, again, those are the ones in the epitrochlear, the intermuscular triangular space, and the popliteal area are there in about 10% or less of cases, so you've got to look for those. Head and neck melanoma has many pitfalls and needs careful interpretation on the sentinel nodes, and SPECT CT may be a good imaging study to use prior to surgery for sentinel lymph node in the head and neck area particularly. So after a sentinel lymph node biopsy is done, if the sentinel lymph node does contain cancer, removal of the entire lymph node basin after the sentinel node is called a completion lymph node dissection. But only about 8 to 12% of additional nodes are positive on completion dissection. So the question became over time, even after we were doing sentinel lymph nodes, was completion lymph node dissection necessary? Yes, completion lymph node dissections can be very morbid. This is an example of a superficial inguinal dissection. We are removing all the lymphatic tissue from the inguinal ligament along the femoral vessels, from the sartorius muscle over to the adductors. So there's a lot of morbidity that comes from this surgery. There's healing problems, there's lymphedema of the leg. So the trial MSLT II was designed to answer whether completion lymph node dissection is necessary in the melanoma. And the trial design was that once a person had a melanoma diagnosed and they underwent a sentinel lymph node biopsy and had a tumor positive sentinel node, whether it was by H&E or immunostains, then they were randomized to either doing a completion lymph node dissection, which was standard of care for many years, or to observe the lymph node base and after the sentinel node with serial ultrasound and clinical exam. And if they reoccurred clinically, then they would go on to have the completion lymph node dissection later. So this was published in 2017 as a completed study and showed that the survival, melanoma-specific survival, was essentially the same whether the patient underwent a completion dissection or just underwent observation. So this was also shown in several other international randomized trials. So now at this point in 2022, the data still supports doing a sentinel lymph node biopsy in the appropriately selected patients, as long as they have clinically negative regional nodes, but we don't have a lot of data to show survival benefit in completion lymph node dissection when a patient with a melanoma in the sentinel lymph node is positive. So a lot of times we don't actually do the completion lymph node dissections these days. And that brings me to my next point. If a patient does present with clinically positive lymph nodes, you do not do a sentinel lymph node biopsy. So clinically positive lymph nodes are obviously large, palpable, firm lymph nodes in a patient who has melanoma. This is an example of a large lymph node cluster of matted nodes in the axilla in a patient with melanoma. This is obviously not somebody you would do sentinel lymph node biopsy on. Another pattern of spread is in-transit or satellite melanoma. The actual definition is that if you have a discontiguous melanoma deposit in the dermis within 2 centimeters of the primary, that's actually a satellite melanoma. And if it's farther than 2 centimeters from the primary, but between the draining lymph node base and the primary, that's an in-transit melanoma. They typically can be have the melanin production, and the dark spots, sometimes you see them as just bumps under the skin, and they may not actually have a dark spot. So follow-up should include both visual looking and for palpation for just bumps that could be in-transit melanoma. This is the most current nodal staging, showing that N1 disease is really just one involved lymph node, but if it's clinically detected prior to surgery and this patient maybe has a clinically positive lymph node, undergoes a completion dissection or just an excisional biopsy, that gives them the designation of B. So N1A is non-clinically detected, found on sentinel lymph node. N1B may be clinically detected, found on either excisional biopsy or a full lymph node dissection. N2 disease is 2 or 3 nodes. A versus B is whether they're clinically detected. N2C disease tends to be in-transit disease with or without lymph node involvement. So N1C is in-transit without lymph node involvement. N2C is in-transit with 1 positive lymph node. N3 disease is 4 or more lymph nodes that are positive. If they are clinically positive, then it's N3B. And if they're 3 or more positive, or 2 or more positive lymph nodes with in-transit disease, then it's N3C. Some subtypes of melanoma I wanted to get into quickly is acrolentiginous and subungual melanoma. So a subungual melanoma is something that grows under the fingernail. This is an advanced one. You would definitely not want it to get to this point. Most subungual melanomas are treated with amputation. As long as you're getting within about a 2 centimeter margin, you do not have to amputate the entire digit. This one was big, so we took it to the base, but you can take it at various joints in the fingers or the toes. It does not have to be the entire digit. So this subungual we took at this level of the toe amputation. So subungual melanomas are 1 to 3% of cutaneous melanomas in Caucasians. They're higher in some other ethnic subgroups. I'll get into that. Most of the time they're in the large digits. So about 50-50 toe versus fingers, but when they're in the toes, 80% of the time they're in the big toe. And when they're in the fingers, about two-thirds of the time they're in the thumb. The most common symptom is discoloration of the nail. Sometimes people have mass or splitting of the nails and bleeding. And it's very difficult to diagnose these. Delaying diagnosis is common, with almost a 2-year period between the initial onset of symptoms and the actual diagnosis. It's tough because you have to remove the nail. You have to sometimes raise the nail bed and do biopsies at the base of the nail. And this can be difficult to do in the clinic. And a lot of times people assume that it's just a nail fungus, and the diagnoses are very delayed due to that. Acrolentiginous melanoma is melanoma of the palms of the hands or soles of the feet. This is an example of a patient with one on the sole of her foot. This is a very deep one. These, when they get ulcerated and deep and big black spots, are going to be a very high chance of metastases, very poor prognosis. This patient had a very deep resection. It's obviously a very morbid surgery. It's difficult for these patients to walk for very many months. It's difficult to heal these wounds since they're weight-bearing areas. So the acrolentiginous melanomas are more common in the African-American population. They account for 36% of all cutaneous melanoma in African-Americans, 18% of cutaneous melanomas in Asian Pacific Islander, and about 9% in Hispanic whites, and less than 1% in non-Hispanic Caucasian white. So we tend to look for these a lot more in our county hospital population here in California. We see a lot of Hispanic Latino X, and so we get a lot of acromelanomas here. Acrolentiginous melanoma has a 10-year melanoma-specific survival that is less than cutaneous melanoma. So it's generally considered to be a worse prognosis. On to stage 4 melanoma. So stage 4 melanoma is obviously metastatic melanoma. And the thing about melanoma, as opposed to a lot of other cancers that have certain organs that it likes to go to, melanoma really can go anywhere. We'll see metastases in the liver, adrenal glands, bowel wall, but you can see it in unusual places, such as soft tissue. The brain is a common place it'll go also, but really it can occur anywhere in the body. This is an example of a right adrenal metastatic melanoma. Here's an intussusception from a melanoma metastasis to the small bowel. In fact, for small bowel metastases, melanoma is one of the most common things to metastasize to the small bowel. And in an adult with a small bowel intussusception, a malignant lead point is a common thought, and any intussusception in a patient with a history of melanoma should be considered to be a small bowel metastatic melanoma until proven otherwise, and frequently should go for surgery to remove that area to prove it. Current metastatic stage 4 melanoma is broken down into the location of the metastasis, and this has a bearing on the prognosis. So M1A melanoma is distant skin and soft tissue metastases, which does not include the draining lymph node basin or in-transit disease. But say somebody has a melanoma on their left arm and they have a right axillary lymph node, that is considered M1A, distant soft tissue or lymphatic metastatic melanoma. M1B is metastases to the lung. M1C is visceral metastases, not brain, but say something like a liver would be M1C. M1D is a new designation, actually just newest in the 8th version of the AJCC, and that is metastases to the CNS or the brain. So this was done before they actually added M1C, but M1A has a better survival than M1B, and they both have better survivals than M1C, and one can assume M1D has a even poorer survival on this survival curve. Some metastatic melanoma certainly can be removed with surgery. Typically, we look at if it's limited to one or a few organs, then you can operate on them. If there's a long period of time between the initial melanoma and the development of metastases, biologically, we may be more comfortable in operating on those. It'd be nice to see a good response to systemic agents, which we'll talk more about the immunotherapy. And patients obviously have to be a good surgical candidate. This is an ongoing area of research. Typically I'd say metastatic melanoma patients should always undergo a period of immunotherapy before going to surgery for metastatic melanoma. I think that's definitely the most common route that we take these days. So let's talk a little bit about systemic therapy in melanoma and targeted therapies in particular. One that you should know about is the BRAF MEK pathway. So these are cell surface receptor pathways. So something on the surface of a cell will signal down through a cascade of proteins to the nucleus, and once that signal gets to the nucleus, it will tell the cell to proliferate, survive, and have immune evasion, which are cancer behaviors. So the BRAF mutation is part of this cascade, and it is the most commonly mutated gene in melanoma in 40 to 70% of melanomas. V600E mutation occurs in over 90% of cases. And there are drugs, BRAF inhibitor drugs, that are used in stage 4 melanoma harboring these mutations. The first article that really talked about this in 2010, they had 32 patients with metastatic melanoma with the BRAF mutation, and given them a BRAF inhibitor drug had an 80% response rate, and the progression-free survival was much better, 7 months versus less than 2 months. So a patient with widely metastatic melanoma that has BRAF mutation, even after just 15 days of BRAF inhibitors, has had a very good response on PET scan. This is a patient of mine that had the large axillary lymph nodes we looked at earlier. They were given BRAF inhibitor drugs and had a good clinical response, and then went on to surgery after that. So using it in a neoadjuvant fashion, essentially. The problem is with BRAF is that there is a resistance to the drug after a few months. So 80% of those with the BRAF mutation will have an early response, but the duration was sometimes only from 2 to 18 months, and then the patients would start to regrow even on the BRAF inhibitors. So the response was considered short-lived. So we don't use these all the time. It's used in select circumstances where there's progressive disease and areas that can be dangerous, such as CNS or other areas that we need rapid shrinkage, but we need something that lasts a little bit longer in response. So luckily, the immunodrugs do provide these longer lived responses. So immune therapy for melanoma is the mainstay of treatment for metastatic or high-risk melanomas. Ipilimumab was the first iteration of the immune therapies, in current use anyway. So T cells fight melanoma. T cells are part of your immune system, and antigen presenting cells would bind to a receptor on the T cells called CTLA4. And when the CTLA4 receptor is bound, it turns off the T cell. So the T cell will not attack cancer cells like melanoma. Ipilimumab was designed to block the CTLA4 receptor on the T cell, thereby allowing continued stimulation of the T cells to attack and kill melanoma and other cancers. So we would see these really great responses, although they were slow, but they lasted. So there's an example of cutaneous metastatic melanoma, and after months and years of treatment, the immune system slowly ate away at the melanoma and continued to have a long, sustained response using ipilimumab. A newer version of the immune drugs that's very commonly used now in melanoma are PD-1 and PD-L1 inhibitors. So the PD receptor is on the T cells, and in this case is typically bound by the PD-L1 receptor on tumor cells, turning off the T cell and inhibiting immune response to cancer. So if we block the PD-1 receptor on the T cell, or we block the PD-L1 receptor on the tumor cells, this will stimulate the T cells to continue to attack and fight cancer cells. So the immune checkpoint inhibitors, again, I have no financial relationship with any of these drugs. These are just mentioned in order to know that when people are talking about these in tumor boards and you're reading medical oncology notes, you know what they're talking about. But ipilimumab and tremelimumab are CTLA4 inhibitors. The common PD-1 inhibitors you hear about in many solid cancers now, actually, even more than are listed here, are nivolumab and pembrolizumab. And PD-L1 inhibitors, you're hearing more and more about, although I'd say less commonly so than the PD-1 inhibitors, but PD-L1 inhibitors include atezolizumab. All right, so the immune therapy side effects, pretty much all of them, ipilimumab, PD-1 inhibitors, PD-L1 inhibitors, all have the same immune therapy side effects. And what happens is the immune system is so stimulated that it'll actually attack parts of the body that it normally would not attack. And it acts almost like an autoimmune disease. So patients will get basically immune-related colitis. They can get bad diarrhea. They can actually get necrosis of the colon, leading to needing emergency surgery. They can get pituitary function problems, pituitary dysfunction, and low pituitary output levels. So basically hypoadrenalism. They can get hypothyroidism. They can get hepatic dysfunction and hepatitis. They can have pneumonitis, they can have skin reactions and rashes, and all these things can be bad enough that it can lead to stopping the therapy itself. So currently the discussion is whether you use combined Ipilimumab and PD-1 inhibitors or use them individually. These are some of the seminal trials that showed why or how we should use combined therapy. So the Checkmate 69-67 trials showed that the response rate of Ipilimumab alone was 11%, whereas the response rate of Ipi and a PD-1 inhibitor like Nivolumab had a much better response rate at 60%, but at the expense of double the toxicity. So toxicity grade 3 and 4, maybe 24% with Ipilimumab alone, but both of them was 50-50. And about half of the patients actually had to drop out of treatment in that trial. The Checkmate 67 trial looked at Ipi alone versus Nivolumab alone versus a combination of them. And the response rate of Ipilimumab alone was 19% with a 27% toxicity and a 2.9-month progression-free survival. Nivolumab was obviously better. Response rate was 44%. Toxicity was lower at 16% and had a better progression-free survival. So typically, Nivolumab is a single agent. PD-1 inhibitor is going to be preferable over Ipilimumab based on these trials. It just has a better response rate, lower toxicity profile, and generally better progression-free survival. Ipi-Nivolumab combination does have a better response rate of 58% and progression-free survival is the longest 11.5 months. But again, it has about a 55% grade 3 to 4 toxicity. And anywhere from a third to half of the patients would have to drop out of treatment based on these toxicities. So I'm a surgical oncologist. I'm not a medical oncologist, but what we see typically is that the Ipi-Nivolumab combination is used in younger patients and in aggressive disease and high-risk disease. And we watch their toxicity profiles, and if they can't take it, then we take them off. But the workhorse of metastatic melanoma treatment these days is single-agent PD-1 inhibitors. And lastly, their future targeted therapy looking will be at the survival for immunotherapy as discussed is sort of slow to take off initially, but is a long sustained improved survival. Whereas targeted therapies tend to have a very quick response, but then they tend to fall off and develop resistance. So combination of using targeted therapies as well as immunotherapies will be continued areas of research to look at improving survival even further in the long run. I think that's about all the time I have, and I think I'm going to go ahead and end the talk there. Just remember sun protection, no matter what you're doing. Thank you very much for your time.